So good afternoon, everyone. I'm José Luis Fernández. I'm director of the Adult Social Care Policy Research Unit, and welcome to this webinar on social care related research carried out across the policy research units, the NIHR policy research units. This is the first of probably what are going to be 4 such webinars this year, 2023. The next one is going to take place on the 22nd of March. Just to remind everyone that we are going to record the seminar. So if you just be aware of this. If you want to sort of ask questions, that will be recorded, and then we're going to post the seminar, the different presentations on the website. So I'm really happy to introduce the first session, to chair the first session of this first day or first webinar, where we've got 3 speakers from 3 different policy research units. One thing I should say is that Jill Manthorpe, who was going to start the session, has had some logistical issues, and so she's now going to switch sort of positions with Francesco Longo. So she's going to now present at around 2:35, and Francesco is going to start the session. So without any further ado, what I'll do is I'll just introduce Francesco. Francesco Longo is based at the University of York. He's linked to the Economic Evaluation Policy Research Unit, and he's going to talk to us about extending eligibility for adult social care, better than investing more in existing users in England, ? So over to you, Francesco.
All right.
By the way, so just one last word, sorry. So the presentations will be 20 minutes. If you can keep your questions to after that, we'll hopefully have 10 minutes for discussion. And you can either write your questions on the chat or just raise your hand, and I'll let you in. Over to you, Francesco.
Thank you very much, José Luis. I will just share the screen, and I will do my best to keep the allocated time. So. Okay, so hopefully you will be able to see the full screen load shortly. So can you give me any? Okay, excellent. Okay, so hi everyone. My name is Francesco Longo, and I'm based in the Center for Health Economics in York. Today I would like to present one of the studies from our EEPRU opportunity cost team in York, and about the correlated quality of life effects of publicly funded adult social care expenditure in England. Of course, during this presentation, you will hear my voice, but also Cal Clarkson, who is part of the team, a very important part of the team, I would say, has joined us today. So I would be happy for Cal to chip in anytime and to help out with questions if you want. Is that all right, Cal? Okay, I'll take that as a yes. Okay, so so in the last decades, social care expenditure has increased over time across OECD countries, and this is because of a number of reasons. For example, because of a rapidly aging population, decreasing availability of informal carers, increasing prevalence of disabilities. In England, however, we can see a somewhat different trend. So if we look at the blue line, so it illustrates the real growth rate in publicly funded adult social care expenditure between 2006-07 and 2019-20. So what is clear from this graph is that right after the 2008 financial crisis, expenditure in real terms fell by more than 2% in some financial year between 2010-11 and 2015-16. Now, some studies suggest that the austerity policy restricted access to publicly funded adult social care, which meant that around 40% of few individuals aged 65 and over did not receive these publicly funded services. And although some of these people replaced publicly funded care with other forms of care, privately funded or informal care, some of them might just have been left with less support. So better news in more recent times. In September 2021, the government announced an investment of 5.4 billion of pound in the adult social care sector. And the new plan has multiple aims, including the reduction of the financial uncertainty around the lifetime cost of social care, but also more investments in the workforce, and extending the eligibility to publicly funded adult social care services by loosening up some of the financial eligibility criteria. So over time, eligibility has changed. And therefore, a natural question for health economists like us is whether changes in eligibility, for example, an increase in eligibility provides good value for money. And in a context where public satisfaction with current services, like in England, is declining, investment decisions should also take into account one more important trade-off, which is between extending eligibility and investing more in existing users. So essentially, with this study, we try to answer these questions. Briefly on the public adult social care system in England. So adult social care is provided to individuals with mental or physical impairment or illness, essentially to improve their quality of life or well-being. There are 152 local authorities that are responsible for these services and provide them directly or through other organizations, and in different settings. For example, institutional settings, let's think about nursing homes, or in the community, domiciliary care. Most of the adult social care services that are publicly funded are means tested based on needs and finances. So to be eligible, first of all, the local authority has to assess the need of an individual as sufficient. But as of today, whatever the level of need, if individual assets are above £23,000, then this determines ineligibility to a publicly funded care, and people will have to pay for their own care. So the new plan is extending eligibility by increasing this upper limit from £23,000 to £100,000. And this, of course, will generate many more people receiving publicly funded care. Local authorities fund adult social care using not only user contribution, as unless income and assets are very low, people receiving publicly funded care still have to contribute to some extent towards the cost of this care. But local authorities fund these services mainly through two sources, council tax and central grants. So grants from the central government, where council tax is essentially a local tax on the occupation of domestic properties. So unfortunately, there are only few studies on this topic. one of the first studies by Forder and colleague, published in Health Economics in 2018, estimates the care-related quality of life effect of expenditure for community-based social care services. The authors analyze cross-sectional data and find a beneficial effect of these services, but with diminishing returns, which means essentially that these benefits tend to decrease as expenditure increases. However, this study does not allow us to disentangle the care-related quality of life effect of publicly funded and privately funded community care services. And overall, this category of social care services represent 35% of total adult social care expenditure, which is a relatively small proportion. So in a more recent study by our research team, we investigate the effect of total adult social care expenditure per long-term user on the care-related quality of life of existing users. Well, just to briefly point out, care-related quality of life as measured by ASCOT. What we do is to analyze cross-sectional data in 2017-18 from the adult social care survey of long-term support users that mostly receive care that is publicly funded. And we combine this data with routinely collected data by local authorities on expenditure and activity, and another huge set of other variables capturing user and local authority characteristics. So what we find is that a £1,000 increase in adult social care expenditure per user increases care-related quality of life of existing users by an amount equal to 0.4% of the average care-related quality of life score. So since our new study builds on the empirical strategy in the previous study, then I will spend this slide talking about the previous econometric strategy. So we have care-related quality of life as our dependent variable of long-term support users I in local authority J, and so publicly funded adult social care expenditure is our key independent variable across the local authorities. And then we have a number of control variables, including eligibility levels and other control variables capturing user and local authority characteristics, measuring the level of need and socioeconomic status. So worth noticing in this regression that we are not controlling for other forms of social care, such as privately funded care and informal care, because through that beta, we want to estimate a net effect, a net care-related quality of life effect, where this effect is essentially the care-related quality of life effect of increasing publicly funded expenditure, net of any care-related quality of life effect that is due to the substitution between publicly funded care and the other forms of care, so privately funded care and informal care. So what's the issue with this regression? Well, the issue is that expenditure is likely to be endogenous because of unobserved confounding, such as unobserved need. And in order to make causal inference and estimate a causal effect, we use an instrumental variable approach, which consists of funding a variable, the instruments, that is a good predictor of the endogenous variable, expenditure, that impact the dependent variable, care-related quality of life, only indirectly through expenditure, and that is not correlated with unobserved confounders, for example, unobserved NATE. And for these purposes, we use council tax space, variation in council tax space, where the council tax space essentially captures the past sale value of all domestic properties within a local authority. So the argument is that since council tax space reflects historical features that are not under the control of the current local authorities, conditional on socioeconomic status, it is independent from social care outcomes and needs. Also, we control for eligibility levels using the type of local authority dummies. There is another study by Fodor et al. Suggesting that the type of local authority, so eligibility policy, varies systematically across these types of local authorities because of exogenous characteristics such as innate culture and market factors. So in the new model, in the new study, first of all, we extend the analysis to more recent years. Then we model the non-linear relationship between care-related quality of life and expenditure by adding expenditure squared, essentially. This is quite crucial because this specification allows us to estimate and to estimate care-related quality of life effects that vary along the distribution of expenditure. For example, if we think about newly eligible users, that is users for whom expenditure changes from 0 to some level, then the care-related quality of life of this user is allowed to vary from the care-related quality of life effect of existing users, that is users for whom expenditure changes from some level to a higher level. Moreover, we relax the assumption that the type of local authority fully captures variability in eligibility levels, and we control directly for eligibility levels using the proportion of long-term support users over the population aged 18 and above. And of course, this variable, the proportion of eligible users, is also endogenous for the same reason that expenditure is endogenous. So we now have 3 endogenous variables: expenditure, its square, and the proportion of eligible users, which we have to predict using instruments. And also in this case, we use variation in the council tax space, and now we use also the local authority type dummies that are now instruments rather than control variables like in the previous model. So through this table, we see so the results that we obtained in the previous study that I mentioned before: £1,000 increase in adult social care expenditure per user increases care-related quality of life of existing user by 0.003, and this is equal to 0.4% of the average care-related quality of life. If we estimate this model for more recent years, we obtain essentially the same answer. And if we estimate the new model for all these 3 financial years, we still obtain consistent findings. So I think that the key message behind this first results is that adult social care expenditure that is publicly funded generates gains in care-related quality of life for both new for existing users. But then the new model allows us to also say something about new users. So let's see how. So in this illustration, we essentially show the estimates graphically or from the new model in 2017-18 for brevity. And what we see here on the left-hand side is the marginal, the estimates of the marginal effect, where the marginal effect is essentially the care-related quality of life effect of increasing expenditure by 1 unit, where 1 unit in our case is £1,000. So as you can see, the highest marginal effect is, we find the highest marginal effect when expenditure is 0, and these marginal effects tend to decrease over time, as expenditure increases. On the right-hand side, instead, we have the estimated care-related quality of life as a non-linear function of expenditure. So this graph allows us to graphically picture what we call no marginal effect, where the no marginal effect is just the care-related quality of life effect of an increase in expenditure by more than 1 unit. So for example, if we think about newly eligible users for whom we increase expenditure from 0 to some level, let's say the minimum expenditure in our sample, then we are likely to obtain on average delta 1 as a care-related quality of life gain. For existing users, for whom we increase expenditure for some level, let's say the minimum expenditure in our sample to the mean level, then we are likely to obtain on average delta 2 in terms of care-related quality of life gain. So now that we have pictured them, let's see some numbers. So the circled number is the marginal effect when expenditure is 0, and we see that as expenditure increases, the marginal effect decreases. And we also have an estimate of the non-marginal effect, delta 1 and delta 2. Now, if we translate these effects in the more policy-relevant social care quality measure, then we can reach the conclusion that to gain, in order to gain one social care quality, we can spend much less in new users rather than existing users. So in sum, what we find is that adult social care expenditure that is publicly funded generates care-related quality of life gains, and this is true for both new and existing users. But existing users benefits relatively more. And this implies that overall extending eligibility is likely to be more cost-effective than investing in existing users. And policy decisions that go in that direction, that is increasing eligibility, are likely to generate a substantial gain in user care-related quality of life. Of course, our study is not free from limitations. Our findings refer only to users of long-term support, so they may not apply to users without long-term support. And since long-term support users are individuals with the highest level of need in the population, then our result may not apply to individuals with lower needs. Also, since we do not have data on non-users, the only way to estimate the effect on newly eligible users is by extrapolation. So the care-related quality of life, to conclude, the care-related quality of life effects are very important and of primary importance for the adult social care sector, but that's not the full picture of the effect of adult social care. So future research should investigate also the effect of publicly funded adult social care expenditure on carers' quality of life, that who are also key actors in this sector, and on other public sectors, for example, the NHS, but also the private sector. Let's think about local economies. Methodological research instead should investigate alternative methods to test the robustness of our results, for example, using panel data method that control for unobserved heterogeneity that is time invariant. Of course, those techniques will require new instruments that vary over time, unlike the ones that we use in this study. Okay, I'm quite done. Thank you.
Thank you very much, Francesco. Can I ask you to stop sharing?
Yes.
It might be easier to have a discussion like that. Thank you very much. So we do have 9 minutes for questions. I'm sure there'll be lots of questions on this very interesting presentation. So please, use the reactions button to raise your hand. Okay, let's have a look. I should be able to get a sense of who. So Simon, do you want to start? Simon Botry? By the way, if you could just briefly introduce who you are, that would be very helpful. Thank you.
Thanks. I'm Simon Botry. I'm a Senior Fellow in Social Care at the King's Fund. Francesco, thank you very much for that. Simple question. Hopefully you give me a simple answer. I'm no health economist, understand. But basically what I'm trying to understand is you're investigating what happens if you spend an extra £1,000, as it were, per individual. If you've got £100,000, does your model give you an indication about whether it's better to spend it on 100 people, 1,000 each, or whether it's actually better to spend it on 500 people of £200 each? I think I've got my maths right. So where's the sort of sweet spot in terms of the benefit in terms of social care quality of life according to the amount of money that you spend? Can you give us anything on that?
So I think that the point is all about whether users are already receiving some services that is publicly funded. So in the sense that if we give that those £1,000 to people that already receive some services, then of course the straightforward answer is that would be probably better to spend those £1,000 on people that are not receiving yet those money in terms of publicly funded care. So that's probably what I would say. We are not probably able to speculate about whether it is better to invest in fewer people or in more people that do not receive care. Probably that's something that our model does not allow us to do. But I don't know what Carl thinks about this.
Briefly.
Yeah, I mean, I guess first of all, the £1,000 per user is because that's the denominator we used in the expenditure. So I wouldn't overinterpret that. The margins are the margins, whether we were looking at £1,000 or £100 or £1. So I think what the model does do is to get the margins for a given level of current expenditure. I think the interpretation is that you're going to get more quality of life gain by spending the same amount of money on those that are currently not getting as much expenditure as others. That's basically the story, and it's the extrapolation to think about eligibility, which is saying, well, what do we gain from moving people from zero public expenditure to some level? And there we get a lot more gain than adding the same amount of expenditure to those that are already getting the average. So I hope that kind of answers the question. I think it all depends. I don't think we can say about whether you should spend the same amount of money on few people or more people. What we can say is that if you've got a certain investment to make, then what this is suggesting is that making that investment on people that have got fewer or no public expenditure available to them is going to get you a bigger quality of life gain.
Thank you. Florin and then Rafael.
Thank you, and thank you very much, Francesco. Yeah, very interesting and relevant work. I have a question more of better understanding the data that you have used. So my understanding of the Adult Social Care Survey is that it has very good information on the quality of life measures, but absolute rubbish information on expenditures. So if I recall correctly, it's only about 5% of the sample you have a positive value of expenditure. So have you used that, or I didn't fully understand if you used instead of that kind of estimated value of expenditures based on other information, or you use that information and instrument it for it. So
okay.
Clarify, please.
Okay, thank you. So, so my understanding of the Adult Social Care Survey is that it does not include information on expenditure at all. So that's something I couldn't find. Probably it's hidden somewhere in that spreadsheet, in that very huge spreadsheet. But what we use to as our variable of expenditure is just the data that we obtain from the adult social care financial returns by the local authorities. And in order to get the per user measure, we use this, what is called the SALT data, short and long-term care activity data that are still collected by local authorities. So these are variables measured at the local authority level, which means that our data set is a sort of multi-level structure. And the good thing of adult social care financial return data is that they include everything. So the full cost of the adult social care for each local authority, which is what we are actually after to answer our research question.
Thank you very much, Raphael.
Thank you very much for an interesting presentation. I'd like to ask you about the unpaid or informal care. I mean, you mentioned it, and you mentioned that you weren't really taking that into account, but abstracting from it in a way that I'm not entirely clear about. I mean, it's clearly unpaid care is absolutely crucial for the care of social care users for many of them who do in fact receive a family care and may continue to do so even when they receive formal publicly funded care. Just wondering if I could ask you to enlarge a bit of what the implicit assumption is in your analysis about receipt of unpaid care.
Yeah, so essentially the idea is that we want to estimate a net effect, where the net effect can be thought as an effect that is also taken into account variability in informal care and privately funded care. So essentially, to better understand what I mean for net effect, we should probably start from the assumption. So essentially, let's assume that all the possible forms of care have a positive effect on, so a beneficial effect on care-related quality of life. So all the three forms of care, publicly funded care, privately funded care, and informal care, they all have a beneficial effect on average, at least. And also, let's assume that there is some substitution effect between these forms of care. So, for example, if I start receiving publicly funded care, probably I don't have that much reason to still buy the same amount of privately funded care or to spend time with my neighbors, for example. So if that's true, then it means that by not controlling in our regression for informal care or privately funded care, we are essentially capturing also the fact that an increase in publicly funded care is reducing those other forms of care, and reduction in a form of care that has a positive effect on care-related quality of life, of course, generates a loss. So essentially, we also capture those losses through our estimate. Let's suppose that now, so since the adult social care survey data also include a variable indicating whether the user is receiving privately funded care and informal care. So let's control for that. Then in that case, keeping those two forms of care constant, we essentially estimate the direct effect of adult social or publicly funded adult social care expenditure on care-related quality of life. And so just to tell you in brief, our findings are that direct and net effect are not that different, which essentially means that people are able to, well, we can speculate in saying that people are able to substitute those forms of support in a way that their care-related quality of life gain doesn't change that much.